So, um, it is my pleasure to welcome you all to the summer series. Big welcome to all of the new and recently upgraded residents and trainees, and hopefully some students as well. Um, I'm really happy because once again, our own Dr. David Tirschwell has agreed to give us a clinical update in stroke care, which at least for me as a non-stroke specialist has been really exciting the last few years because there are a lot of changes and they're great to hear about and be aware of. So thank you so much, Dr. Tirschwell, for agreeing to give this talk.
Thank you. Can you hear me okay? Yes, okay.
Yep.
I'm going to go ahead and get started. So this is my favorite old picture of Harborview, and you can actually see my office window from this view, and I'll buy somebody a cup of coffee if they can point it out to me later. So I'm going to start with a case, and then we'll be talking a lot about acute ischemic stroke care. If you are brave enough to try to interrupt me along the way, I'm happy to take questions, but I can't really see the chat very well, so that won't work. I'm also happy to take questions at the end. So our case is a 75-year-old woman's husband who calls 911 saying she had the sudden onset of right-sided paralysis and trouble talking. And of course, all of the amazing neurology providers already know this is a stroke happening. And I just wanted to flash this up because in Washington State, there is a pre-hospital stroke triage algorithm that all EMS services across the state are supposed to be largely in compliance with. And so the full document is on the right there, and you can look at it at your leisure at that website on the bottom. But I've summarized it on the left here. So if there's any chance of stroke, they do this FAST assessment to look for face, arms, or speech abnormalities, which is a good screening test for stroke symptoms. And if that's positive, they do this stroke severity score, or the Los Angeles Motor Score, LAMS. And then where that EMS team will take the patient depends on the time since they were last known well and what their Los Angeles Motor Score, or LAMS score, was. So if they're within a 6-hour time window where maybe they got the time wrong a little bit, it's at least reasonably possible they might be a TPA, IV TPA candidate, and they have a high LAMS or high severity score, they'll usually go to the closest stroke center. But if there's a higher level stroke center not too much further away, then they can actually bypass a closer, lower level center, go to a higher level place, often that has thrombectomy capability. In the 6 to 24-hour window, especially with the high LAMS score, the EMS providers have the ability to go even further down the road, up to 30 or 60 minutes extra travel time to get somebody directly to a thrombectomy capable center, since they're probably not going to get IV TPA at a local smaller hospital. And then after 24 hours, they'll always just go to the closest stroke center, regardless of how sophisticated their infrastructure. These rules kind of end up applying differently in rural versus urban settings. In a very rural setting, there's no higher level stroke centers even within an hour. So they're always going to end up just going to the closest hospital, even if it's a small place, and then they can get transferred to a higher level of care. So this document, this acute stroke evaluation and treatment algorithm, is on this website. You need a UW Net ID to get in there and look at it. It's something that's been evolving over more than a decade, being updated with new treatments. The interesting and I think cool thing about this document is all of these kind of teal blue things in the document link out to other PDFs that have informational stuff. So there's actually a lot of information that you can get to about acute stroke care from this one website. So we're going to start at the top there. The first steps in the emergency department. Our stroke code now is called if a patient presents within 24 hours of last known well, and that stroke code rapidly activates an extended team of providers, including stroke docs, neurology residents who go immediately to the ED. CT techs are notified, interventionalists, pharmacy, anesthesia. And in those first 15 minutes in the ER, the patient is being met at the door. There's a short history and physical, and they're always going directly from the door to CT if we knew that there was an acute stroke coming in. Depending on what we get with the history and physical, and then especially after the non-contrast CT, we like to emphasize ordering IV TPA as early as possible if you think there's a reasonable likelihood that the patient will get treated with it. If the patient also has a large vessel occlusion, we use this app on cell phones called Pulsara for communication during our stroke codes. I'm not going to talk much about that today, but we have a way to sort of activate the interventional team as well by toggling a button in that app. So there's lots of structure and lots of people involved in these stroke codes. So if we go back to our algorithm, we were just talking about this ED staff stuff at the beginning, and then if we then go down to the next box here, which is the radiology part, what happens with acute stroke initial imaging? Well, first, and certainly the most important, is the non-contrast head CT. It's incredibly fast these days and requires very little patient cooperation, very reliably rules in or out a hemorrhage versus no hemorrhage, and thus more likely an ischemic event, which is what we're talking about today. Theoretically, all you need for an IV TPA decision is that non-contrast head CT and your history. And then I'll talk a little bit more about in a few minutes. There's this aspects scoring system that we apply to non-contrast head CTs, looking for early ischemic changes to make thrombectomy decisions. Our non-contrast head CT, when there's no blood, is always followed by a CT angiogram. And for ischemic stroke patients, that includes the neck and the head, although it's called a CTA of the neck. It's also very fast and relatively easy immediately post CT. We do that because we can often identify pathology, proximal artery occlusions that can give us a clue to why this patient had a stroke and may represent a target for mechanical thrombectomy. If we do find a large vessel occlusion, we then go on to a third variety of CT scan, a CT perfusion scan, to again try to make decisions about appropriateness for mechanical thrombectomy. The perfusion scans mostly apply to large vessel occlusions in the anterior cerebral circulation. All right, so we got the CT scan, there's no blood, and let's say that the time since the patient was last normal is less than 4 hours and 15 minutes ago. In this type of scenario then, we're on our algorithm here, and we're actually talking about possibly giving IV TPA. The goal is that once we make the decision to give IV TPA and we've ordered it, we should try to give it within 15 minutes. Our best practice goal is from door to TPA getting started through the IV in 30 minutes. Our quality goal is to try to have 50% of our cases reach that 30-minute door to needle goal. We do have IV TPA orders, which are in Epic. I guess I have to go back and change all these things that say CPOE to Epic IV TPA orders. And the emergency department docs actually help in the Harborview ER putting some of those orders in. There is a TPA information sheet that you can link to, although more often than not, it's just a verbal description of the risks and benefits to the patient and or their family to get consent to give the TPA. If the patient is unconsentable and no family can be reached, TPA can be given as a standard of care. Careful consideration by the Neurology team, both the residents and the attending, is paid to the inclusion and exclusion criteria. The residents, in our system at least, are discussing all of this with the stroke phone, either the fellow or the attending. And if the patient qualifies, we try to start that TPA as soon as we feel it's safe and appropriate. All of the post-IV TPA patients will be admitted to the ICU for at least 24 hours, as is the case also after thrombectomy. There is a possible hemorrhage post-TPA protocol I'll show you in a second. Again, there are blood pressure guidelines that are built in to the EPIC order sets for IV TPA patients that you're admitting to the hospital. A lot of these standards of care that I'll be referring to throughout are incorporated into the EPIC order sets. So really important to use the appropriate stroke order sets as you're admitting these patients to the hospital. So here is a graphic, and I could spend a half an hour going through this one slide, so I'll skim over it a little bit. But on the left side is the algorithm, again, that you can link out to from that stroke document, and that also I think is on your stroke cards that the neurology residents have. It's an algorithm to follow if you're suspicious of an intracranial hemorrhage soon after IV TPA. And it reminds us that if the TPA is still running, you should stop it. You get a stat head CT and blood draw for some coagulation parameters. You order up some cryoprecipitate. And of course, when you have a moment, you would be updating a patient's family about a change in status. If the CT is delayed, then you can empirically give some cryoprecipitate if the fibrinogen is low. And then depending on what you find on the head CT, you might also give tranexamic acid and repeat some of your blood work. Again, trying to call and keep all of the provider team in the loop about the whole thing, updating the family. If the head CT is negative, and even though you're worried about hemorrhage and then you don't see it, we have for many years now gone with the standard of not restarting the TPA, and recently had an email exchange with some of the other faculty about this point, and there's no real evidence one way or the other on this, and opinions may vary. So there could be some variation on that theme, but that's been our on this algorithm for quite some time. On the right side, and I'm not going to go through this in detail, but you should know where it is. At the end of the TPA inclusion and exclusion criteria document is the management of the pretty rare complication of orolingual angioedema post-IV TPA administration. All right, I like to include this slide because the benefit of IV TPA, which you can see on the y-axis here, is very much dependent on the time from last known well to when you start the treatment, which is what is on the x-axis. And so the benefit goes down and down the longer you wait until, after 4.5 hours, we're not as confident that it's effective anymore. So 4.5 hours is the time window that we still cleave to largely. And I'll tell you a little bit about a possible exception in a couple of minutes. But it suggests that even if your patient gets to the ER way back here at just an hour after the onset of their symptoms, to maximize their chance of benefit, you still should be going as fast as possible to get their IV TPA started. So let's modify our case a little bit here. A 71-year-old woman has atrial fibrillation, had a previous ischemic stroke that was treated with IV TPA, but had no residua from it. Had trouble keeping her INR steady on anticoagulation, so was put on a NOAC, or now more commonly referred to as DOACs, direct oral anticoagulants, but had been off of that for a few months for financial reasons. Presented to an outside hospital with right weakness and dysarthria. NIH stroke scale score was 13. the outside hospital CT showed a middle cerebral artery occlusion. And because they thought she was taking the NOAC, they didn't have a good communication. They didn't treat her with IV TPA, and she was transferred to Harborview for possible thrombectomy. And here's a CT angiogram, which shows nicely pointed at with the red arrow, the occlusion of the sort of distal M1 segment of the middle cerebral artery. And I'll just take a couple of minutes now to talk about the Aspects scoring system, and that stands for the Alberta Stroke Program Early CT Score. And it's a reproducible grading system to assess early ischemic changes on and on contrast head CT. It's appropriate for patients with acute ischemic stroke in the anterior circulation. It is not terribly complicated, and they say it is reliable, but I do feel like we often debate what the actual aspect score is. It was used in a number of randomized trials for mechanical thrombectomy as an entry criteria. And if you had lots and lots of early ischemic changes, you would have been potentially excluded from some trials. So how you do the scoring, you start with 10 points. That's a normal brain. And 0 means lots of early ischemic changes. And to compute the aspect score, you basically subtract 1 point from 10 for every abnormal area of these 10 regions on the right side. So there are 4 deep regions: the caudate, insular ribbon, internal capsule, and lentiform nuclei. And then there are 6 different MCA territory areas. 3 are more inferior, 1 through 3, and then 4, 5, and 6 are a bit more superior. And this is what they look like, those different areas on some cross sections of a head CT, starting down in the temporal lobes and going all the way up pretty close to the vertex. And then here's an example. So here's a non-contrast head CT. Let's say we think that anterior temporal area, the M2 area, has some abnormality. So that would be 1 point. And the insular ribbon looks like it's grayed out there. So that's another point. And then the lentiform nuclei are a bit blurred in this case too. So that's 3 different areas of abnormality. The rest were unremarkable. So here the aspects would be 10 minus 3 or 7. And if we bounce back to our acute treatment algorithm, this patient does have a large vessel occlusion. It is in the anterior circulation, so she should probably get a CT perfusion study and be considered for possible endovascular or mechanical thrombectomy. And these are some of the steps with the thrombectomy option. Obviously, the resident and/or fellow are discussing it with the stroke attending. We get the neurointerventional team involved. Again, there's an information sheet, but more often than not, there's verbal description and consent with the family done by the interventional team. Again, there are inclusion and exclusion criteria. And if they qualify and consent, they'll go for the procedure down to the angio suite. And again, there are order sets for admitting these patients to the ICU. And just to give a little bit of the background of the randomized trial data that support the substantial benefit of mechanical thrombectomy for acute ischemic stroke, this is a patient-level meta-analysis from 5 randomized trials. And what you can see are these horizontal bars where the modified Rankin scale is a measure of outcome, usually at 90 days. And here, good outcome was dichotomized as a modified Rankin of 0, 1, or 2, which means that, a 2, you do have some deficits, but you're still able to walk and take care of your own affairs pretty well. So that's a decent outcome. 1 is no real disability, but symptoms, and 0 is almost perfect. And you can see that in the control group of over 600 patients, only about 26.5% had that good outcome of a modified Rankin of 0 to 2, whereas in the thrombectomy group, it was actually 46%. So the number needed to treat, which is derived by this formula, 100% over the intervention group good outcome minus the control good outcome. So it's 100 over about 20, means that the number needed to treat is about 5, which is a very powerful and effective intervention. These were trials that really addressed the early time period of 0 to 6 hours since last known well in acute ischemic stroke. And then here's a graphic, another one that shows the relationship on the y-axis between the odds of having a better outcome, and on the x-axis, time from symptom onset to arterial puncture for your mechanical thrombectomy. And this one, the y-axis is a logarithmic scale, which I think is why it looks a little flatter. But again, there's a statistically significant relationship where the longer it takes you to get started and get your treatment, the less likely you are to benefit. Again, urging us to get these interventions done as quickly and safely as possible. And it's why I and many other members of the stroke team in many departments across the hospital spend a lot of time talking about these processes of care on a regular basis to keep the machine running smoothly and efficiently. So these turn out to be the criteria for patients that end up being the best early 0 to 6 hours thrombectomy candidates. And it's rated as a very high level of evidence, class 1 level of evidence A. So if you were in good shape before your stroke, modified Rankin of 0 to 1, if you not only had this large vessel occlusion, but you already got IV TPA, if there's an occlusion of the internal carotid or proximal middle cerebral artery, usually the M1 segment, and I've got the M2s there in parentheses in orange, because we will sometimes go after M2 vessel occlusions, but there's less evidence supporting that intervention. This is mostly applicable to adults, but we have done this on some teenagers and have had some great outcomes. You have to have a reasonable neurologic deficit, so a score of greater than or equal to 6 on the NIH stroke scale. But again, sometimes we'll go lower if it looks like the patient really is at risk for worsening. You have to have an aspect score, which we just talked about, of greater than or equal to 6. So you can have up to 4 areas that have early ischemic changes. But some data suggest that aspect scores even down as low as 4 or 5 may still benefit from thrombectomy. And you're supposed to get that groin puncture within 6 hours of last known normal. And in this 0 to 6 hour time window, you do not necessarily need a CT perfusion study showing mismatch to do the intervention. But if somebody's in the scanner already and they have good IV access, we will usually proceed and get a CTP nonetheless. All right, so back to our case. We'll add a little bit of nuance and detail. We were pre-notified that the patient was coming and the stroke team was waiting for the patient. She arrived at Harborview 3.5 hours from the last known normal. Here it was the witnessed onset of symptoms. The NIH stroke scale score was 11 with right-sided motor and sensory abnormalities, as well as some speech abnormalities. And this is the patient's CT scan on the right. So again, I'm starting my aspects review. So here's some abnormalities in the lentiform nuclei, maybe a tiny abnormality in the M4 region. So, and that was it for this scan. So here aspects 10 minus 2 abnormal areas equals a score of 8. So that certainly wouldn't exclude them from being eligible for thrombectomy. It would allow them to proceed. So everything was hitting just right that day, and she got from the door to puncture in the angio suite in 38 minutes time. And this was the first run on the angiogram, and you can see the sharp cutoff in the proximal middle cerebral artery there. And again, of course, I'm showing you one of our fantastic cases, but the intervention was with a stent retriever, began just a few minutes later. And you can see that this patient had really full reperfusion of the territory of the middle cerebral artery. The NIH stroke scale score went down to 3 to 4, including an immediate improvement after the procedure. And eventually the patient was discharged home instead of, possibly needing skilled nursing facility if they hadn't been able to get this procedure. I'm showing you this MRI because even in a fantastic outcome case, we often see something like this, where there's a lot of small punctate areas of infarction in somebody who did have a proximal large vessel occlusion, but in whom we were able to get it open. There is intensive monitoring for the first 24 hours after these interventions, as there is, and as is the same as for post-IV TPA patients. The blood pressure goals are the same as post-IV TPA, and there are also additional groin puncture site checks and pulse checks in the lower extremities. Okay, moving on a little bit, I think you're all probably aware that the time window for mechanical thrombectomy has now been extended out from what was first out to 6 hours, which was huge, to now out to as far as 24 hours. And that was based on these 2 trials published in the New England Journal of Medicine, the Dawn trial in late 2017 and the Diffuse trial in early 2018. And the key thing about both of these trials is that they end up having advanced imaging or CT perfusion study imaging parameters to qualify for thrombectomy in the extended time window. So this is a summary result image from a CT perfusion study. It's processed by this proprietary software called RAPID. It summarizes the criteria from one of the trials, the Diffuse 3 trial, which looked at patients between 6 and 16 hours from last known well. And what you can see is that there's 2 sets of slices. On the left side, there's a part of the brain that's highlighted in pink, and that represents the area where cerebral blood flow is less than 30% of the normal volume. And that's supposed to estimate, it does a good job, it's been validated as estimating a core of brain tissue that is already dead. And to qualify for intervention, that has to be less than 70 cc's. And in this picture, it's 22 cc's. And then on the right side of the screen, the green area, which represents the part of the brain where the time to maximum contrast arrival is greater than 6 seconds, that's been validated as representing the area both of core and additional tissue that is at risk. So the core plus penumbra. And so when you subtract the core from the core plus penumbra, you end up with the penumbra. This mismatch volume to qualify for thrombectomy has to be greater than 15 cc's. In this example, it's actually 45 cc's, and the mismatch ratio to qualify for intervention has to be greater than 1.8. Here, it's actually 3. So if somebody came in, if our patient came in at 12 hours and had this CT perfusion result, this would be a good candidate for mechanical thrombectomy. Smallish core, bigger penumbra. Let's save that penumbra through our mechanical thrombectomy. And here are the results and number needed to treat from the Dawn and Diffuse trials. I've clumped them onto one slide for efficiency. And what you can see is that actually, by those same calculations, the numbers needed to treat here in Dawn was just about 3, and in Diffuse was 3.6, suggesting that with the criteria that these trials put together in the right patients, these late window thrombectomies are even more effective than the ones in the 0 to 6 hour time window, which is amazing that we have an effective intervention for some patients who qualify in the extended time window. Some people believe that this amazing number needed to treat might suggest that the criteria for doing the mechanical thrombectomy are too stringent, and that maybe some wiggle room around the edges will still lead to effective interventions. And part of that is why we sometimes will expand the boundaries of who we're willing to do these interventions on a little bit on a very much case-by-case basis. If you link to the mechanical thrombectomy criteria from our acute treatment algorithm, this is part of the document that comes up. You have to have a confirmed large vessel occlusion. I've underlined the basilar artery occlusion because if you go down to the asterisk at the bottom, there's no clear time window established, and any suspected basilar occlusion is a potential candidate for IV TPA as quickly as possible. If standard IV TPA criteria are met, and they also are potential thrombectomy candidates. Many times we'll do a rapid, shorter set of sequences, code stroke MRI, to see how much tissue is damaged before going into the basilar artery occlusion, but we tend to be very aggressive with those as the natural history outcomes are often pretty bad. The other criteria I've mostly talked about, the diffuse criteria I explained on that CT perfusion slide. The Dawn criteria, which really would only apply for us, we think between 16 and 24 hours, are a little bit different than the diffuse ones. They use age, NIH stroke scale score, and just the core infarct estimate from the CT perfusion. They don't use the penumbra as much. They sort of take the NIH stroke scale score as a indirect marker of the size of the penumbra. Okay. So what about blood pressure post-thrombectomy? There hasn't been much evidence in this space, although I'll show you in a sec a recent randomized trial. So patients who undergo mechanical thrombectomy, reasonable to maintain blood pressure less than 180/105. That's the same recommendation as the post-IV TPA blood pressure monitoring, but they kind of admit, and these are from the 2019 American Stroke Association guidelines, they admit that the level of evidence is really only moderate and it's not based on randomized trials. And then let's see, as I said, limited evidence. Most thrombectomy patients also got IV TPA, part of why they're the same. Some of the trials have suggested more aggressive goals. The ESCAPE trial suggested a normal blood pressure. The Dawn trial suggested less than 140 post-reperfusion. And then as I was reviewing the literature, getting ready for today's talk, I found this randomized trial called BP Target, which specifically addressed this issue. It was published in the Lancet Neurology this year. It was a randomized open-label trial looking at patients with anterior large vessel occlusions that were successfully treated with mechanical thrombectomy, and they compared immediately post-thrombectomy systolic blood pressure goals, an aggressive goal of 100 to 129 versus a more standard goal of 130 to 185, and they had to be randomized within an hour. The primary outcome was radiographic brain hemorrhage, because the thought was the higher blood pressures might increase the risk for hemorrhage, so maybe we can lower that by being more aggressive since we've got the vessel open anyway. And there was a safety outcome of hypotension. They managed to randomize 324 patients who had pretty significant strokes. The average NIH stroke scale score was 18. And I just wanted to point out that the hemorrhage that they defined were all four of these categories. There's this Heidelberg bleeding classification of bleeding events after ischemic stroke and reperfusion therapy. And it goes from something as simple as HI1, which stands for hemorrhagic infarction 1, which is just scattered small petechiae, to PH2, which means parenchymal hematoma. And PH2 is the more serious one, hematoma occupying 30% or more of the infarcted tissue with obvious mass effect. And so hemorrhages in any of these four categories were part of their primary outcome. And what you can see in the closest to intention to treat analysis on the top is that in the intensive group, 42% had the primary outcome. The standard treatment group with higher blood pressure is 43%. So there was really no significant difference. Also no significant difference on secondary outcomes like favorable outcome. Symptomatic intracranial hemorrhage was actually a little higher, though not statistically significantly so in the intensive group, and the hypotensive events, not much different either. So no reason to be crazy aggressive with blood pressure goals. And I would say that this is the best evidence that I've ever seen on this topic. So, okay, let's talk a little bit more about IV-TPA. People have been trying hard to extend the time window for IV-TPA, and there were two trials published in 2018 and 2019 that looked at this. The Wake Up trial, 500 patients who had an unknown onset. They basically woke up with their stroke or presented aphasic and we couldn't say when they had their stroke. And basically you could be randomized to TPA versus not if you had this MRI diffusion flare mismatch. So you could see their ischemic stroke on diffusion weighted imaging, but their flare sequences, you couldn't see it. They also had to not be going for thrombectomy, and they found about an 11.5% absolute benefit. So that's, a number needed to treat of about 9 or so. So not quite as good as mechanical thrombectomy, but still effective. And then there was what I consider a slightly less effective trial. They looked at a 4.5 to 9 hour window post last known well, or this complicated thing about if they woke up less than or equal to 9 hours from the midpoint of their sleep. And they used actually a CT perfusion parameter to decide who might be eligible for the extended time window TPA. Slightly different than the parameters we use for mechanical thrombectomy. The ratio only has to be 1.2. The difference only has to be 10 mLs, where it has to be 15 otherwise. And the core max is the same, has to be less than 70 mLs. And they had to do statistical adjustment to get their main result to be significant. And this graphic here, I just like to include because it shows you for the Wake Up trial, this is what DWI flare mismatch looks like. You can see the infarct on DWI, but not on flare. You can see it on DWI, but not on flare. Versus these patients who wouldn't qualify, you can see it on DWI and flare, DWI and flare. So it's this top row of patient, which honestly, we don't see much in our emergency room. And I don't think anybody sees too many of these patients around the country. So questions that remain about the extended IV TPA time window. I think the MRI Wake Up trial is better evidence than the Extend trial. In Extend, 2/3 had Wake Up timing, so it would really fit under this one as well. In this study, there were very small cores and large penumbras, and many would have probably been good thrombectomy candidates, but when the trial was going on, they weren't treating these patients with thrombectomy. So it's hard to know how to apply those results. Some of this stuff may be more appropriate for small hospitals where mechanical thrombectomy isn't an immediate option, versus here, if we got somebody in a late time window and they were a good thrombectomy candidate, we're probably just going to go straight to thrombectomy and skip the IV TPA. And I will add, there have been a couple of trials looking at skipping IV TPA in patients who are going to mechanical thrombectomy. And there's, I think there's some equipoise there. Some of the trials have shown that there isn't much of a benefit. Others, maybe that there is. So, for now, our standard of care is still to give IV TPA if they qualify and then go to mechanical thrombectomy. All right, so in our stroke algorithm, this late IV TPA consideration is in this box here. One other thing about IV thrombolysis that continues to get a lot of discussion, and there's still a lot of ongoing randomized trials, is the possible use of IV tenecteplase instead of IV TPA. And you know, the main reason to choose it, I believe it's less expensive, but more importantly, it's one IV push instead of an hour-long IV drip. It's much easier and more convenient to give. These are the recommendations about tenecteplase from the 2019 American Stroke Association acute ischemic stroke guidelines. May be reasonable to choose tenecteplase over IV TPA, who are also undergoing mechanical thrombectomy, because that's what probably the most recent trial and where it was positive. But they also say that it's not been proven superior nor non-inferior, which is a lot of statistical specificity about what we know and don't know. And so the recommendations are at this 2B level, which is sort of weak and, you know, might be reasonable, might be considered. Effectiveness is unknown. So not an overwhelming amount of enthusiasm. And then these come from European Stroke Organization guidelines for IV thrombolysis for acute ischemic stroke. These just came out a few months ago in 2021. And they say for patients with acute ischemic stroke less than 4.5 hours, duration and not eligible, they suggest IV TPA over tenecteplase, though admit that the evidence is low. And then for those that have a large vessel occlusion, again, you might consider it, but also they say the evidence is low and weak. Standard blood pressure treatment after stroke. Drug-induced hypertension is not something that has a lot of evidence. And so in patients with blood pressure less than 220 over 120 who don't have IV TPA or mechanical thrombectomy to treating blood pressure acutely. So then my last big topic is early antithrombotic therapy. And I know I'm running up against my 45 minutes. Sorry about that. If you got IV TPA, all antithrombotics are delayed for 24 hours. Anticoagulation is generally avoided early after acute ischemic stroke, even in atrial fibrillation. A few exceptions are listed there. If you have a non-cardioembolic minor stroke or high-risk TIA and you present early, then dual antiplatelet therapy, usually aspirin and clopidogrel, has become a standard of care. A new alternative, perhaps, is ticagrelor plus aspirin, and I'll show you a little bit of data from those trials on the next slide. The duration of this dual antiplatelet therapy is just 3 weeks, short, which helps decrease the risk in a high-risk period, but doesn't expose you to the risk of a bleeding complication with long-term treatment. And then if you have a non-cardioembolic, more major stroke, you may use aspirin alone, or if you're an aspirin failure, you might use clopidogrel alone. Sometimes dual antiplatelet therapy will be considered, perhaps in patients with really severe atherosclerotic disease, although there's less evidence for this in more major strokes and probably more risk. And if you have a cardioembolic stroke, first aspirin. And then I say here 81 daily, I meant to suggest that we are actually doing a weight-based dosing, as I comment on up here, after that initial day. Less than 70 kilograms, 81 a day, greater than 70 kilograms, 325 milligrams a day. And then usually anticoagulation for secondary prevention will be started by 14 days at the latest. The timing may depend on the size and whether there's hemorrhagic conversion of the infarct. And this is a very brief summary of the Thales trial, which came out in the New England Journal last year. 11,000 patients with minor ischemic stroke or high-risk TIA randomized within 24 hours to ticagrelor plus aspirin versus aspirin alone for just 30 days. There was no change in disability. The editorial came out saying this was strong support for aspirin, but there was a statistically significant hazard ratio of 0.83 reduction with the dual antiplatelet therapy, but there was also a hazard ratio of 4 with an increased risk of severe bleeding on the ticagrelor aspirin combination. And so this rather complicated slide, which I'll not go too deep into, shows on the left side the chance and point trials, which were the aspirin and clopidogrel trials, which show a big benefit in the first 21 days and some increased risk of hemorrhage, but not quite statistically significant. In the Thales trial, the overall event rates were a little lower. I tried to equalize the y-axes. And stroke of death was a little bit less in the early time period, but the hazard ratio for major hemorrhage was quite a bit higher than it was with the aspirin clopidogrel combination. So, you know, ticagrelor, at least in our practice, has only really started to come in as relevant for patients who have failed dual antiplatelet therapy with aspirin and clopidogrel or have allergies, but there's a lot of talk about it on the global stage. So other treatments for acute ischemic stroke, if you're in a small hospital, we love to encourage CT and CTA. IV TPA can be done in small hospitals, telestroke support, and trying to minimize the time from the door in, door out to a higher level stroke center. Stroke units are very important for patients to receive care in. They've been proven in randomized trials to decrease mortality and increase independence. We have evidence-based blood pressure targets I talked about like that. Everybody should get DVT prophylaxis and a dysphagia screen prior to taking any PO intake. Euglycemia is great, but we don't have to be too aggressive, and that's based on the SHINE randomized trial, which showed that a glucose target of less than 180 was just as good as more aggressive targets. Rarely, including last night in a case here at Harborview, decompressive hemicraniectomy might be appropriate for a malignant middle cerebral artery stroke, or large cerebellar strokes sometimes have a posterior craniectomy. And I'm just going to summarize this a lot. It's hard to do any talk today these days without talking about COVID-19. If you do this search in PubMed, there are 605 publications as of yesterday. When we think about treating stroke in patients with COVID-19 or unknown COVID-19 status, the goal is to give the same exact care, but to take extra precaution. It might slow things down just a little bit. We should try to minimize the extent to which it slows things down, but there really shouldn't be any treatments that are off the table just because we're suspicious of the possibility of COVID-19. This graphic on the right shows that just as the pandemic began and hit really hard in March of 2020, the number of CT perfusion studies plummeted like 30 or 40% as patients stopped coming to the hospital because they were so scared. This graphic here, I'm not going to go through in the interest of time. It's in this great review article that I'll show you a picture of at the end. So just to summarize, when you're seeing an acute ischemic stroke patient, you want to identify the time last normal, get that brief history. You're doing your CT and CTA immediately to define your disease. And if there's a large vessel occlusion, a CT perfusion study. Very urgently want to make your decisions about IV TPA or thrombectomy. Antithrombotics will be started early, the timing depending on what other interventions they got. They get all these other standard treatments that I just mentioned, plus early rehab, and then later statins and anticoagulation for secondary prevention. If you want to read more, there are 3 excellent reviews that I've pulled out here within the last year or so. That graphic that I had up a few slides ago comes from that most recent review on the right there from JAMA. And that's it. Thank you for your attention.
Thank you, Dr. Tirschwell, for that whirlwind tour of the to me, like stunning changes in stroke care since I was a trainee, but maybe that's getting further and further away. But it's really exciting to see like the differences people can make. And I hope what people get out of this is what I at least think of from a public health perspective is that hopefully these will accumulate to significant changes in longer term outcomes too, about, you know, how many patients end up needing nursing home care and the burden on their caregivers. Because these are certainly common and strong enough effects that I would hope it has these kind of reverberating benefits at a pretty big scale. But let me help with the chat. Dr. Perlman asked a question that I love. Is there a role for precision medicine in choosing drugs for secondary prevention of stroke? That is, such as genetic resistance to clopidogrel. And I'd add, should we be looking for aspirin resistance in certain patients?
Yeah, so there's not a lot of high level evidence showing that intervening in those situations makes a difference in patient outcomes. There's some data in the cardiac literature about clopidogrel resistance, you know, genetic testing. As far as the platelet function testing, really fraught. And there are multiple different assays that don't always agree with each other. And again, nobody's ever shown, save in some very small series, that changing behavior based on those measurements really improves outcomes. I will say I absolutely expect it to be coming. And you know, there are cases where somebody's come in on clopidogrel and they've had a recurrent event, and we'll sometimes send off the clopidogrel resistance. But if they fail, we're often likely to change their therapy anyway, just because it feels like we should do something different, even if there's not a ton of evidence to do it. So, I mean, I would say we do a massive amount of personalization because we're doing all these diagnostic tests. We're imaging, we're trying to nail down the specifics of the cause of their stroke, and that often modifies our antithrombotic therapy, you know, blood pressure medications, statins, all that kind of stuff.
Let me add something too. I feel like there's a lot of common secondary complications, associations of stroke in like the subacute and early after stroke outpatient setting, things like depression, sleep apnea, cognitive decline. Is there anything that can or should be done in the acute or early aftercare to screen for those, since some of them are treatable or modifiable?
So certainly it's very appropriate to screen for depression, and as we see patients every day, often that can be fairly obvious at times, and we have a low threshold for treating it. Sleep apnea is an important question of which our faculty have a particular interest in, and in fact, we're participating in an ongoing randomized trial looking at early sleep apnea treatment after ischemic stroke and TIA to see if it, number one, improves functional outcomes, and number two, decreases the risk of recurrent events over the first 6 months. So that's a great question. And then as far as cognitive decline goes, I think mostly we just work on it. It's absolutely a thing, and it's accelerated post-stroke. But mostly secondary prevention is our strongest tool to intervene there, in addition to rehabilitation and stuff. But there's not a lot of high quality evidence suggesting that rehab slows cognitive decline either.
Okay.
David, that was a great talk, as always. My question has to do with how well what you've described could be applied in other parts of the world. I mean, there are other parts of the world where stroke is a much more important problem, and especially low-income countries. How well would any of this be applied there?
Well, so that's a great question. And, you know, I would say that though I have highlighted some of the more sophisticated interventions because they're the coolest and most complicated to think about, that many of the simpler interventions that I talked about, like being taken care of in a stroke unit, DVT prophylaxis, dysphagia screening, many of these things can also make significant impacts in patient outcomes. And, you know, IV TPA is something that is starting to be used in some lower income countries because it's not as complicated. You just need a CT scanner, and that's becoming more and more accessible. Certainly, mechanical thrombectomy is going to be really hard to implement in the majority of the world, save the higher income countries. But I would absolutely suggest that many of those simpler interventions, which, you know, maybe I should proportion my slides to the number of people we're saving around the world, then I would have talked a lot more about stroke units than mechanical thrombectomy.
Mm-hmm. Kind of slightly on that, Raphael Wobble wrote in the chat, does EMS give aspirin if they're concerned about stroke?
They don't know if it's ischemic or hemorrhagic, and it's not any more complicated than that. And so they don't.
But there are some places that do a mobile CT to get around that.
There are. That's a can of worms. And in fact, the mobile stroke units, MSUs, give TPA in front of people's houses. They can't actually be traveling while they're doing their CT and stuff because it's too bumpy. But they can certainly get IV TPA, you know, with a CT scan, and often a neurologist videoing in to weigh in on the intervention. And that's something that's also being figured out. You know, in a medically dense city with an amazing EMS system, the added value of a mobile stroke unit is not entirely clear, but there are people out there attempting to demonstrate the benefit of mobile stroke units.
I mean, we're a medically dense city with a pretty well tied in neuro stroke team. Is that anything that people have considered doing here?
Well, it's very expensive, first of all. And there has been a sponsor that approached UW Medicine, but it has to be integrated with EMS, and EMS has to play fairly with all of the hospitals in the city, for example, or county. And so, you know, for a sponsor donate a mobile stroke unit and then have it branded at one place, it's super political. At the end of the day. And I would say that our EMS directors, as I alluded to indirectly, are not convinced that it would really add a lot to care.
Yeah. But if we say time is brain, and you've showed that graph of the declining returns, literally in an hour, which definitely getting a patient to a hospital and scan can take more than that. It sounds like some of those concerns are more about who's going to pay for it than whether patients might benefit enough for it to be worth it.
Yeah, and I mean, where do you put the mobile stroke unit? And there's quite a few issues.
Okay, we got a lot of chats here. This is exciting. So I'll keep my thoughts to myself. Amelie Lafon says the decreased stroke incidence gets ascribed to fear of coming to the ED, but could some of it be due to less non-COVID infection? AIS decreased at SCH and other ped stroke programs during COVID?
Yeah, I mean, that's a great question. So was that decrease in strokes due to just people staying home with their strokes, or were they staying home with their strokes so scared that they took all their medications and, you know, worked out on the elliptical every day because they had nothing else to do, and also got less infections, which can be a risk factor for having a stroke, an inflammatory procoagulant state or some such. So yeah. I think that's a great question. I imagine it's some of all of that.
Yeah. Well, there are even studies showing that the people who've gotten their shingles vaccine have a significantly decreased risk of stroke. So Wainwright, Dr. Wainwright says, are there any promising neuroprotective drugs in trials now, or have the many failures of these drugs, his words, reduced any prospect of progress in this field?
So, you know, we're part of the NIH StrokeNet network of randomized trials. And I will tell you that I do not think the NIH is currently, the NINDS at least, is currently funding any neuroprotective trials. I think there are still some commercial things that are going on out there, but it has been a huge disappointment over the years.
Well, and Dr. Weiss, is a follow-up question, basically, I think that edaravone has been approved in Japan for acute stroke for years, and more recently for ALS. Is it being studied for stroke in the United States?
I haven't looked at this in a while, but there are some data out there that were less than convincing, and I don't think there was ever a big Western trial.
Yeah. I mean, I think that ties in, at least to me, a little bit, that, some of these big trials that are done in different countries with different ethnicities who tend to have different types of strokes may explain some of the differences. And, do you have any thoughts about the main trials that you quoted? What was the socioeconomic, ethnic background of those patients? And can and should we be extrapolating them so strongly to everybody? Were these trials really representative of the UW population? And should they be extrapolated to other countries with big different ethnic
it's a great
cardiovascular
question.
risks?
I think we have some a little bit of Western arrogance probably in the way these things go, because the American Stroke Association guidelines are sort of held up around the world as the best standards of care, and most of those are based on trials that happened in the Western Hemisphere. It's a great question. I think there have been experiences where some of the trials that have been done elsewhere around the world weren't done as rigorously, and when repeated in the United States, didn't show the same benefits. So I think that's part of why the Western crowd and the FDA, for example, is a little bit skeptical about trials that have been done in other places.
Yeah.
And I mean, certainly the NIH trials that have been funded strive very much for racial diversity, although, achieve it to a limited degree.
Yeah. And I would say locally, one glaring example of that is that, there are numerous studies showing that Native Alaskans, Native Americans, and Hawaiian natives may have one of the highest stroke rates of any ethnicity ever studied. But I strongly doubt that any patients from those ethnicities were included in any of these trials that we point to. And here would be a great place to study that further. Is anyone looking at stroke?
Even though we have perhaps a reasonably greater percentage of those populations, there's still a very small group in absolute numbers, and it would be really difficult to study, especially in randomized trials.
Yeah. And a lot of them, there's definitely a geographic preference that they often live far away from acute stroke centers, So in speaking about how to provide care to a population and how to dedicate resources, I do believe that there was one mobile stroke unit that was studied in the Navajo, but I might not be remembering right.
I'm not aware of that, but could be.
Okay. Well, we're at 5:33, and luckily, I hope everyone will have lots more opportunities to learn from Dr. Tirschwell clinically and formally in lectures. So that's wonderful.
And there's a couple more questions in the chat. I'll type answers.
Okay. Thank you.
Great job, David.
Thank you.
I took notes.
I'll send you the PDF.
That'd be great. Bye.
Bye.